Tricuspid stenosis is a valvular heart disease characterized by the narrowing of the tricuspid valve orifice, which creates a mechanical obstruction to blood flow from the right atrium into the right ventricle during diastole. While tricuspid stenosis is relatively rare compared to left-sided valvular lesions, it typically occurs in conjunction with mitral or aortic valve disease. Rheumatic heart disease, the most common cause globally, it almost never occurs as an isolated rheumatic lesion and is nearly always associated with mitral stenosis. Carcinoid syndrome often leads to fibrous plaque deposition on the endocardial surfaces, resulting in both tricuspid stenosis and tricuspid regurgitation. Congenital tricuspid atresia or congenital webs. Other causes: infective endocarditis with large vegetations, right atrial myxoma, systemic lupus erythematosus, that is Liebman-Sachs endocarditis, or iatrogenic causes such as pacemaker lead interference. The latter two are unlikely to cause significant tricuspid stenosis. Tricuspid regurgitation is more likely. The narrowing results in a pressure gradient between right atrium and right ventricle. Unlike the left side, even a small mean pressure gradient, like more than 5 mm of mercury, is considered clinically significant. That is because it is a low pressure system and the tricuspid valve has the largest cross-sectional area among the heart valves. Systemic venous congestion. Elevated RA pressure is transmitted backwards into the vena cava, leading to jugular venous distension, hepatic congestion, and peripheral edema. Reduced cardiac output. Limited right ventricular filling leads to decreased stroke volume, particularly during exercise. Fatigue and dyspnea due to low cardiac output. Right-sided heart failure causes abdominal fullness or bloating due to ascites, right upper quadrant pain due to hepatic congestion, and lower extremity edema. Jugular venous pulse is characterized by a prominent flickering A wave due to forceful atrial contraction against a stenotic valve. Auscultation reveals a soft, high-pitched diastolic rumble heard best at the lower left sternal border. Unlike the murmur of mitral stenosis, the tricuspid stenosis murmur increases in intensity during inspiration, the Rivero-Cavallo sign. Echocardiography is the primary tool for